My remit is to really present to you the increasing role of one-stage exchange and the way we've been using it in our hospital for the last decade. These are my disclosures, which are not particularly relevant to this presentation. When you think about periprosthetic infection, the key is not just to settle for eradication of infection and prevention of recurrence. What we must do is focus on function and on cost containment, and those are two areas where single stage may have a high role to play. The reality is the debate that whether you should do single or multi-stage revision will continue, but my view is there's time for change now. Because the principle is actually exactly the same. Whether you do single or multi-stage, you must identify the organisms, you must then physically eradicate the problem with good surgery, and then you can reconstruct into a healthy bed with a certain amount of antibiotic in the system. And that pertains to single or two-stage. And the accepted dogma that you will hear from Dr. Masri in a moment is that two-stage is the gold standard. And it probably is the case in terms of the literature, but not necessarily for every individual patient. Now, single-stage revision does have a history. It's based around aggressive surgery using hinged implants at the endo clinic with antibiotic-loaded cement, and they've showed very good results with that kind of surgery. There is a paucity of literature outside the endo clinic, mostly from Mike Freeman, whose recent publication of 50 patients now followed up into the long term in the Bone and Joint Journal suggested that outcomes of 90% or more can be achieved without the endoclinic approach. In other words, without very aggressive eradication of the ligaments and soft tissues. The other issue that has arisen in recent time is that we've started to routinely use interval spacers. So if we can leave foreign material in, why not leave a definitive prosthesis? You will, of course, also be aware of an increasing literature around the use of antibiotic-loaded cement in the interval period and of shortening the period of intravenous antibiotics. There are also a number of series that have now shortened the interval period. So that led us to the concept of selective one-stage exchange in those patients whom we thought we could do that in. Our proof of concept was carried out over 15 years ago in the hip and published a few years ago, where we carried out a strategy of selective single-stage exchange, followed up to 5 years, and found that there were no reinfections and better function in the single-stage group. So in 2004, we set out with a similar protocol for the knee, which I'd like to summarize for you briefly. What we did is we chose our easier patients, those who didn't have immunocompromise, who had healthy soft tissues, minimal or moderate bone loss, and in particular those where we could identify an organism and knew its sensitivities so that we could apply local antibiotics, and we picked those for the single stage. Our procedure is very simple. As I said, it's the same whether you do single or two-stage. What you must do is try and get a diagnosis, as you just heard eloquently. We then do a standard debridement and lavage and send multiple samples, but then instead of putting a spacer in, we redrape, we get new instruments, and then we do an immediate reconstruction. They then get IV and then oral antibiotics as guided by a multidisciplinary team, which is critical to all this working. The reality is that what Dr. Masri is going to describe with two-stage is what we still do for the more complex cases where the patient is immunosuppressed and is a poor host, where the organism is complex, or where there's polymicrobial infection, or where we do not have an organism to target. So we've looked at our data. I'll just share this with you. This is a minimum 3-year follow-up of 102 patients who followed that protocol, where 28 ended up with single stage and 74 two-stage, all in the same institution, all independently followed up. The majority were osteoarthritic, but there were some inflammatory arthropathies here who tend to be poorer hosts. If you look at this very busy slide, it gives you the differences between the two groups, and you'll see, not unexpectedly, that the ASA grade, general fitness, is worse in the two-stage group, and of course there is an interval in the two-stage group, which there isn't in the one-stage group. And one of the big differences in terms of health economics is that the two-stage group spends a much longer time in hospital than the single-stage group. If you look at the organisms, you'll also see a difference, because the MRSAs and MRSEs and the polymicrobial infections are, of course, in the two-stage group, and that's something that we yet have to bridge. But then if you look at our data, our single stage, these highly selected, fitter patients have no reinfections. they have better knee scores, and they have higher satisfaction. So for those individual patients, the outcome is better. There are social advantages, there are economic advantages for them. It's only one operation, it's a shorter hospitalization, and they get back to their work and their activities earlier. And so far, we haven't paid a price in terms of reinfection. So our patients like this idea. You will also all have patients who've been through this. It's occasionally the case that you will do a revision that you think is aseptic, and yet when you get your results back from the lab, you find that you grow some organisms. We've done that on 19 occasions, some in the hip, some in the knee. None of these have been reinfected. So single-stage revision in that context clearly works. So just to summarize for you, because this is a complex area where there is great debate and there's a great deal of almost religious belief in one approach or the other. The reality is, I think we are shifting. This is a terrible complication which is difficult for the surgeon as well as for the patient. It is enormously expensive for the healthcare system. So approaching it from a single-stage perspective will help you, your hospital, the patient, and ultimately the healthcare system. And remember that getting rid of the infection alone is not enough, because the patients will often end up with functionally inferior results. There are papers out there that suggest good results in the long term with spacers, but we all know, doing a big volume of infection surgery, that once you're coming back in the second, the third, and the fourth time, it is much tougher than operating less, because the soft tissues are much less tolerant. So I would advocate for you a selective strategy, whereby you pick the winners. You take those uncomplicated cases and start doing single-stage revision. You have to be supported by a multidisciplinary team, you have to have good diagnostics, and you have to have a good OR team. But in reality, we have shown great success rates for those cases. Those are now over a quarter of our infection practice. I would predict that that's going to increase radically as we gain confidence and as we realize that we can make single-stage exchange work without having to do radical endoclinic type clearances. Two-stage is still there in the background for the more complex cases. So I would suggest to you that the world is really changing. In 2014, infection is still a big problem, but there are some patients in whom we can get single-stage exchange to work if you're in an appropriate centre with the appropriate backup. Thank you very much indeed.